Hello, I'm Kate Walker. I'm the lead methodologist for the National Bowel Cancer Audit, and I'm the senior methodologist on the National Cancer Audit Collaborating Centre. Quality improvement, as the name suggests, is the improvement of care and outcomes for patients across the country. So not just improving the quality nationally, but trying to reduce variation in quality across the country. The main shift at the moment is that we are able to get cancer data nationally much more quickly. So whereas we've had a lag of upwards of 18 months from a patient first being diagnosed and treated to actually getting the data on them, we're now reducing that to just a few months, and we're also able to get that data more frequently. So that means that we can report back to hospitals their own data more frequently and in a more timely way than we've ever been able to do before. As well as the frequency and the timeliness of the data, we're also getting much richer data. So over the 10 years or so that I've been involved in cancer audits, we're now getting more data on chemotherapy, the exact drugs patient has had, when they had it, the radiotherapy, the doses, where they had it, the imaging data, new genomics data, so genetic testing of the types of cancer patients have and whether they're undergoing the correct tests they should. It's just getting richer and richer, so more and more information about the patients, about the care they have and outcomes of that care. NATCAN has audit teams for each cancer audit that it runs, and within those teams we have methodologists who can work out the best ways of analysing the data, together with clinicians who are able to guide us to the most important questions and the most important issues around analysing the data. So together we've got that methodological expertise, but the on-the-ground clinical understanding of the issues for patients. Yeah, so we have complex patients in terms of age, deprivation, ethnicity, comorbidity, for example. And when patients arrive at hospital, first diagnosed with cancer, they're not entering at a level playing field. So when you're comparing the care and the outcomes of hospitals, you need to take into account these complexities about the patient, about their cancer, so that you can make fair comparisons between hospitals. If you don't do that, then you're unfairly penalising, for example, hospitals that treat higher risk patients. You could even be discouraging hospitals from treating the high risk patients. And then from a patient perspective, it's important to understand how all of their risk factors affect their outcomes so that you can help them with shared decision making on the best treatments available, or you are able to identify the really high risk patients who need the higher levels of care. An example is patients undergoing emergency surgery for bowel cancer. The very high-risk patients need consultant-level care in theatre, and they need to be transferred direct to critical care from theatre. And so if you're able to model and understand their risk based on all of their characteristics, then you're able to identify which patients need that higher level of care. Yeah, the advance we have now is that we have much richer data on the complexities of the patients and their tumour. The genetic data we're getting is brand new, and then also the exact treatments that patients get. The treatment pathways are getting a lot more complicated for a lot of cancers, and so we need that more granular data to actually be able to see what all those different treatment pathways are and to see the variation in care, to try and understand that variation.